Good afternoon, everyone. Going to share the slides and get this QI course underway. Okay. I trust that everyone's able to see those slides okay. Give me a nod if you can. Okay, awesome, perfect. Thank you. Okay, so welcome. This is the Quality Improvement 101 course. Just make sure you're in the right place, and you are. And today, along with my colleagues, Gloria Thorington and Carla Lisa, we will be talking about why QI matters. It's always a good place to start, with the why, and then jump into core concepts and models and project planning and management. My name is Laura Vanderhill, and I'm a social worker and senior quality improvement specialist here at Health Centric Advisors. And it is my privilege, along with Gloria and Carla Lisa, to be your guide for this QI course over the next several weeks. And we hope you're able to attend all sessions, but if you're only able to attend a few, that doesn't matter. It's great to have you here, so thank you for joining us. Alrighty. So our objectives for the course overall is to be able to, start with that, the why, and really break down the quality and process improvement methods that are available to us. There's a lot of them. We're going to be telling you, a lot about it, and we just encourage you to pick and choose what you think would be helpful for you and whatever project you're working on. And, we're also going to look at how to, collect, analyze, and use data for improvement. I'm sure you all know data is so important. We're going to look at applying learning and skills to a project or an opportunity for improvement at your organization. So a little bit of homework and look at, really building on that in the coaching calls on Thursday. So more support to come. And we look forward to supporting you as you go along this journey with us. So, looking at, just to break this down a little bit further, looking at sort of those core elements specifically today of the organizational QI program and plan, it's always got to start with the plan, right? We'll look at the PDSA, Plan, Do, Study, Act model is always another good place to start, and discuss project initiation and the use of a project charter and other project management tools. And I'm going to turn it over to Gloria for that piece. So as I'm sure you all know, we're in good company here. You got to start at the top, right? Leadership is really the important place to start. It fosters a culture of quality, it sets the tone, and empowers others. And so looking at systems thinking here, systems thinking is where you're using, you're, trying to inspire, have that shared sense of purpose around a, culture committed to quality. You want to instill that board to bedside accountability framework, promote team-based agile learning, and advocate for a just organizational culture and a psychologically safe environment. Everyone wants to be able to come forward with concerns without that fear of retribution. And we're also going to talk about how important it is to have health equity as your foundation for all QI work. And then, of course, you also have infrastructure in addition to systems thinking. It's everyone, is involved in QI. It's not just the QI department, right? So looking at infrastructure, we want to standardize systems and communications and workflows, engage across all departments, like I just said, and, provide ongoing quality, safety, and cultural, I like to say humility, education and training, and recognize all those great outcomes that you have from the QI efforts. You always want to, celebrate those successes. It's so important. So as I said, we're starting with the QI plan. A plan is the who, the what, the when, the where, the why, and the how. It comprehensively defines the specifics of everyone and everything involved. And if you have the execution that's successful of an overarching QI plan, then it's going to be very proactive. It's going to be looking at equity, like we are going to be, coming back to equity throughout this, right? And looking at also reducing costs and improving, outcomes and care delivery and all those good things. So all these, I think a important piece of the QI plan, which we'll build on in just a little bit, is, making sure that you have that patient and family, or if you're in a nursing home, your residents and their families having that engagement, using your patient and family advisory council to inform that plan, and really, gathering input from all stakeholders. You want to communicate with intention. So having, that representation, looking at, having your C-suite sponsor, right, or champion, um, you know, physician champion, and, could be one and the same, right? The what's in it for me approach can be helpful. That's really knowing your audience, right? Knowing your audience, what motivates them. The C-suite is going to be like, how can we save money, right? How can we improve patient satisfaction, employee retention, safety results? Frontline staff is going to be, do we have a workflow that works, right? Do we have improved patient and resident outcomes? For physicians and providers, it might be we're really utilizing those evidence-based practices, value-added processes, and again, of course, improved patient outcomes. And we always want to align your messaging, make sure kind of everyone's on that same page, and use the data that you have and the lived experience stories. It's really important too, to personalize the message and connect with the audience. So as I was saying, patient and family engagement, or resident and family engagement, is so key. And we have a lot of resources around this. So if this is something you're interested in taking a deeper dive in, please let us know. And, of course, I mean, the why is so clear, right? It's so obvious. You want to have it be that folks have a voice, and that voice can be really helpful in ensuring that you have high quality, safe, and effective care. So for those who are not new to QI, and this is really more of a refresher, I'm sure you've heard of Deming. A lot of what we're going to be talking about today is from Deming. And, we're going to be looking at the PDSA, of course, today. And a systematic method for improvement, it has, several different goals, if you will. And, it's just coming back to linking the quality and the equity. Equity is foundational and QI is foundational, right? You can't have one without the other. They really do come hand in hand. Just like you can't have, quality just be in the quality department. You can't have equity just be over here on the side, right? It, needs to be embedded in all the different work that you do in your organization, a cross-cutting component, as we say. And QI methods identify opportunities, they can address root causes, and work to close those gaps and drive progress, leading to those sustained improvements, which is what we all want. So why use a QI model? Well, it helps guide your projects and provide feedback, so you know what's working, what's not working. There's no one size fits all. And I think that's why, it's so great that there are different models. So you can pick what is like a better fit, or, one model's not working, you can try a different one. But they all kind of have similar design concepts. And they come from different industries, and then they were adapted, right? They come from manufacturing and were adapted for use in healthcare, as I'm sure many of you know. And it's really about, sort of starting with a small change and seeing if it makes the difference that you're looking for, and building off from there. So here's the PDSA, right? And, this is sort of the, again, foundational model, if you will, or cycle for quality improvement. And what's unique about PDSA is it has this emphasis on many cycles in rapid succession at a small scale, right? So just starting, one population within like one department, focusing on one aspect is really where you want to start, because otherwise it can be overwhelming and maybe not effective. And so in the plan stage, you're really deciding what change you will make, who's going to do it, when it will be done, formulating a hypothesis about what you think will happen when you try to change. You want to identify quantitative and or qualitative data that you can collect that will allow you to evaluate the results. In the do stage, you can carry out the change and document problems and observations, begin that analysis. Study, you want to complete the analysis, you want to compare the data to your original hypothesis and kind of see, what did we learn here? And then act is, what changes do we need to make? What does the next cycle look like? How are we going to implement, right? So it's just sort of a continuous process. So IHI, they have a lot of great resources around the PDSA. And, this is how they, thanks to Deming, conceptualize the model for improvement. And I think it's always good to, start with questions, right? What are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in improvements? That's really, you got to start with the planning and the thinking, the brainstorming, and then the PDSA is the doing part. And that gets everybody on the same page and sets the scope of the project. So we have our aims. We're looking at measures, right? So how will we know? We have to set measures. Otherwise, we're not going to know that the change was an improvement. And then, what are the change ideas in terms of, is there already evidence that exists to support this improvement? What new ideas have we come up with? And what can we learn as we go along? And then it's jumping into the small tests of change with the PDSA cycles. So IHI, quality improvement structure, it indicates that QI efforts need all of these good things, right? So you got to have that clear aim. You have to have the measures. You need a clear description of the ideas, a clear description of the strategy that you're going to use, dedication to those PDSA cycles, understanding, describing, and visualizing systems such as process maps. So we'll go through all of this, through the course. This is just getting us started. Learning, about variation. So, looking at the use of time-ordered data to detect some special cause and improvement, and understanding why results differ by location. So, what you do in one department, it may not have the same outcome as another department, right? All right, so I'm going to turn it over to Gloria to jump in about the tools that we have to help us figure all of this out. So, Gloria, why don't you take it away?
Thank you, Laura. Yes, glad to be with you here today. We're going to start out and talk about project management plans and documents. A vitally important part of QI work involves managing your project to ensure that targets and goals are achieved. Project teams can use assessments, plans, and other relevant tools and documents to guide their activities and manage their efforts in addressing a specific priority, topic, or problem. And you can see here on this slide some of those different documents. And we're going to talk about a few of them today, and we'll go more in depth as we go through this course. So next slide. Here we go. So what is a project charter? A project charter clearly establishes and details the goals, scope, timing, milestones, team roles, and responsibilities for a QI project. The charter is a living document. It's typically developed during project initiation by the QI oversight team, and then it's given to the project team. It's a valuable document that helps teams have a clear understanding of what they're trying to accomplish. Um, as a living document, it needs to be updated as the project progresses and revised as the team gains additional knowledge and gathers new information. It's essentially agreement between the project sponsor, project champion, project manager, and the QI team. Each time the charter is revised, it is going to be initialed by the project sponsor, project champion, and the project manager. The project charter also helps to answer key questions. There are multiple project charter templates available. Carla Lisa is going to give you a link to the IHI project charter that you're seeing here. Next slide, please. This is an example of another project charter template. This one actually is a CMS copy form, and is used by home nursing homes. And again, Carla Lisa will give you the link to that, and she'll also provide a guide to the use of it. Next slide, please. Okay, so this is the project planning form. The IHI project planning form is a useful tool to help teams think systematically about their improvement project. This includes a listing of the changes the team is testing, the PDSA cycles for each change, the person responsible for each test of change, and the time frames for each test. The form allows a team to see the overall picture of the project. The form can be used at the start of a project to initiate planning. Begin by thinking about the drivers that the team will focus on. Identify an interim goal for maybe 90 days for each driver, and the process measure used to track progress on that driver. Then you're going to want to list the changes you will undertake for each driver. Assign responsibility for each task and estimate the time needed for testing, implementation, and spread. And consider how you will gather the data needed to evaluate each test of change. And you're going to update this form regularly as the project continues. Next slide. Thank you. So let's go over this form in more detail. First, create that numbered list of drivers, focusing on key leverage points in the system that are opportunities to influence outcomes and achieve your aim. Next to each driver, identify a process measure and a goal. Process measures define in specific terms how you will measure the driver to evaluate the results of your tests of change. State a measurable goal for each driver, specifying what you want the results to be after your changes. And next, you're going to fill in the grid for each driver. You're going to want to ask, what idea for improvement will you test? What tasks need to be performed to set up and run the test? What are the details of your test? And who is responsible for each task you identified? And how many weeks are expected or needed for each phase of the improvement cycle? So you can see testing, implementation, and spread. And those are identified by T for test, I for implementation, and S for spread. This one, the project is lowering depression scores and achieving a 15-point decrease in PHQ-9 scores for 50% of depressed patients by May 1st. And you can see the drivers there, patient education, follow-up assessment, and the process measures and the goals. And then you can see what their change ideas are and the tasks they're going to do to prepare for their tests. Next slide, please. So next we're going to talk about driver diagrams. We're not going to go into depth on this today, but when we meet on Thursday for coaching, this will be one area where we'll really go into depth and talk about. So I'm just going to go over it today, and then we'll talk about it further on Thursday. So a driver diagram is a visual display of a team's theory of what drives or contributes to achieving the project aim. It provides a clear picture and helps to communicate to stakeholders what the team is testing and working. It shows the relationship between the overall aim of the project, the primary or key drivers that contribute directly to achieving that aim, the secondary drivers that are components of the primary drivers, and specific change ideas to test for each secondary driver. So the primary drivers are the most important influences on the aim. And you should only have a few of these, maybe 2 to 5 at the most. Secondary drivers are influencers or natural subsections of the primary drivers. And you may have as many as you want of those. As each driver is identified, establish a way to measure it. Remember, it's highly unlikely a single person has a clear view of this entire complex system, so it's wise to enlist the help of team members who are familiar with different aspects of the system under review. So the driver diagram is included in the IHI QI Essentials Toolkit. And again, Carla Lisa is going to help us out by putting that in chat, putting a link so you can access that in chat. On the left of the project aim, which includes what will be improved, is by how much, by whom, and by when. So you can see here, it's to reduce by 50% colonization and infection with MRSA by August 1st. So you can see that is by how much, for whom, and by when. And to the right of the aim are a few primary drivers, the most significant high-level influencers on the aim. Each has a line to connect it to the primary drivers of the aim. And then to the right of each primary driver are the list of the many secondary drivers that influence the primary driver. Each secondary driver has lines to connect them to the primary drivers. The secondary drivers can connect to more than one primary driver, which you can see here. And to show strong relationships, use solid lines. To show weaker relationship, use dotted lines. And to the right of each secondary driver, you're going to see a list of specific change ideas you will test to influence the secondary driver. Change ideas can connect to more than one secondary driver. Next slide. So we're going to talk now about how to establish SMART goals. These are goals that serve as the team's vision of what it wants to accomplish. Your short-term and long-term goals will drive your action plan. And we'll be talking more about action plans in different classes as we go along. When thinking about developing your short and long-term goals, consider the following guidelines for making them SMART goals. Again, you want your goals to be specific. Make your goals measurable, thinking about how you will measure or evaluate if the goal is reached. Make your goals obtainable and be able to defend the rationale for evaluation measures you defined in the previous step. Make your goals relevant, describing how the goal will address the disparity you'd identified. Be sure your goals are time-based, setting a target date for achieving the goals. Remember, we aren't adding any action steps at this point to address the goal. We're just thinking about what we want to accomplish. And this clearly articulates the goal and will help the team to see the bigger picture. So a sample goal that's here is improving staff hand hygiene compliance on a specific unit for West from 80% to 100% within 3 months. And again, you can see how that's very specific, and the goal is time-based, has a target date, it's measurable, and something that can be evaluated. Next slide. So, as mentioned earlier, integrating health equity and a reduction of disparities as a cross-cutting strategy in all of our QI efforts is essential. You'll never truly have quality or safety without health equity. You need to be sure that you consider health equity and disparities when you're analyzing and problem solving to improve care and outcomes in all harm areas. Ensure you're providing workforce cultural competency training and conduct self-assessments and analysis of results to ensure an improved delivery of culturally and linguistically appropriate competent care and services to diverse populations being served. Establish culturally and linguistically appropriate goals, policies, and management strategies, and infuse them throughout the organization's planning and operation. For all harm areas, work to collect, stratify, and analyze data by race, ethnicity, language, and other social, economic, and determinants of health data. Use the results to tailor interventions to meet the needs, not just to meet the needs, but inform this data with your PFACs and patient advisors. So let's discuss an example of that and why it's so important. So in Michigan, we had a hospital that was trying to increase their COVID vaccination rates within a certain service delivery area. They decided they would rent some space and create an extensive campaign to increase COVID vaccines access within these areas. They assumed that this would help solve their problem, but it wasn't informed by those that they were attempting to reach. After failing to increase vaccine use, despite them believing that they had increased access, they tapped into a PFACT, their PFACT, who was comprised of a diverse group of individuals that matched the populations that they were serving. Based on a review from the PFACT, the hospital soon realized that the locations they selected weren't on bus routes. And many of them required multiple transfers from the surrounding communities to get there. And it would actually take hours for people to reach it. So that's why it's important to ensure that you're including multiple perspectives, including patients and families, can be critically important to your success. Remember, as they always say, nothing about us without us. Next slide. So let's move on to data management plan and establishing measures. Measurement is a crucial part of testing and implementing changes. Measures inform the team if the change is effective and leading to improvement. There are 4 types of QI metrics: structural, process, outcome, and balancing. Next slide. So structural measures assess the infrastructure or the physical environment and facilities. So an example of a structural measure is the availability of hand sanitizer pumps or determining if you place central lines. A case example here is, does your hospital use e-prescribing for controlled substances? Next slide. So process measures assess the activity performed. They can be very helpful in determining where a breakdown may be occurring in the process, leading to a negative or worsening outcome. These process measures often capture the evidence-based best practices an organization is putting into place to improve. Each step in the process can be tracked and measured, but over time and after you have a good sample size, you can identify which process steps are the most important for preventing negative outcomes and just track those. So again, an example of a process measure is hand washing compliance rate. So a case example is assessing a step in the care of a patient. So the percent of patients prescribe opiates at discharge through e-prescribing. Next slide. So just a minute. So outcome measures assess the final product or results, and these should reflect the impact mode. So an example of an outcome measure is CLABSI rates. So if you're working to decrease your CLABSI rates, that is an outcome measure that you can look at. So another case example, assessing the effectiveness of care or the results of care might be the rate of opiate-related adverse drug events. And then last is balancing. So balancing measures assess the unintentional negative impact on a different part of the system. So an example of a balance measure is you may be trying to improve something with the patient, but you end up having staff skin breakdown. So another case example is assessing for unintentional outcomes. Decreased opiate prescribing results in an increase in patient pain management rates. So next slide is now we can talk somewhat about our data management plan. It is the overarching plan for how to collect and use meaningful data. It serves as a baseline, identifies problems, root causes, it measures our progress, and it monitors sustainability. It provides details like who, what, when, where, and how of each measure used to support a QI project. Your team can choose to just look at one key metric, such as hand washing compliance rate, or your team can choose to look at a couple measures such as hand washing compliance rates and CLABSI rates. Next slide. So, what is a project communication plan? This communication plan tool defines and outlines who the stakeholder is to receive communication, the action to be taken, the measure content, delivery method, and frequency. It also includes information on the team structure, including team members, roles for the project, and contact information. You should also include information like status updates, task-related questions, meeting details, and data reports. Transparency is so important, it's so helpful in obtaining buy-in. Alignment and engagement and meeting the expectations will be critical to your success. A communication plan is a great way to help the plan for how often stakeholders will receive information and help your team to meet those deadlines. Next slide. So this is an example of a communication plan. And again, this is something that Carla Lisa is going to put in chat, a link so you can have a copy of this. And if you want to use this as a template when you're doing your projects. Next slide. Okay, so in this example, we're working on the communication plan for CLABSI reduction. We know that we'll need to ensure that we're communicating with the med surgical unit staff as well as our leadership team. For the med surg unit staff, the team needs to create a flyer and an email to help inform them of the CLABSI reduction project that will be initiated on their unit. But additionally, we want to seek participants from the staff. A flyer is going to be posted on the communication board. Emails are going to be sent to the staff. A flyer eventually, there will likely need to be another column providing regular updates to the med-surg staff on about the progress being made and the plan for implementation. In this example, the other plan communication will be to the leadership team, specifically focusing on updates and resource requests. These communications will occur biweekly via email and will help to provide updates to the designated leadership on the progress of the project and make any requests of resources that may be needed to be successful. It's important to remember that the communication plan is meant to be another living document that you're likely plan for many communications with throughout the duration of your project. And some items, such as frequency, may need to be updated as your project progresses. Next slide. So, change is hard. And while all this information may sound great, certainly talked about a lot of different areas about project management, we know that people are resistant to change. And as Mark Twain says, the only person that likes change is a wet baby. So next, we're going to talk, and Laura already has the slide up. Thank you, Laura. We're going to talk about resistance to change. Why are so many people resistant to change? For many people, change is uncomfortable. All change is a new beginning, the end of something else, even something you liked. Endings are unsettling, and people may respond out of fear, anxiety, or self-preservation. Next slide. So, let's talk about barriers. Barriers are actual restrictions placed on your project. There are many types of barriers. It can be a physical barrier, like a lack of supplies or equipment, such as a lack of inpatient beds for admitted ED patients. Team members may be fearful of being open and honest in communication, and that can end up being a barrier. There could be insufficient financial support. It's another barrier to implementing project goals. For example, if you need new beds or surfaces for critical care patients to decrease pressure injuries. There may be political issues can get in the way, and it's difficult to engage stakeholders in collaboration due to personal agendas. Current policies often need to be revised if we find that they don't match current evidence-based practice. What's done and what the policy says are two different things. And these, again, may be a barrier. Staff disengagement or local culture may not support adapting or adopting change. They don't see a reason to change or keep a mentality of that's the way we've always done it. There may be resource barriers, not enough staff, equipment, or supplies to implement or support our project goals. So how do we overcome our barriers? Well, we should try to change the narrative and mindset from a negative to a positive. For example, instead of saying, we have to change your process, frame it as we get to improve our process. Make sure you identify barriers specific to your QI project. If there's more than one barrier, you'll need to prioritize them. Knowledge is half the battle, and once barriers are recognized, then problem solving can begin. And as it says here, engage cave people in your problem solving. So cave people are stands for Citizens Against Virtually Everything. And it's a term coined to describe people who oppose any kind of new development or change. And Carla Lisa, again, is going to help us out by putting a link in chat to an article on cave people and some things you can do to overcome those barriers. So our next slide, we're going to talk about Everett Rogers' innovation diffusion theory from the 60s. And it's going to help to explain resistance to change. When faced with a new change, people often fall into one of 5 types, somewhere within this bell curve. So you can see on the left-hand side, 2.5% are innovators. These are the people who want to be the first to try the change. They're venturesome, interested in new ideas, and our innovators are the willing to take risks and often the first to develop new ideas. Very little or anything needs to be done to appeal to this population. Next slide. So the next are our early adopters. These are people who represent opinion leaders. They enjoy leadership roles and embrace change opportunities. They are already aware of the need to change and thus are very comfortable adopting new ideas. Strategies to appeal to this population include how-to manuals, implementation, information sheets. They don't need information to convince them to change. So our next is our early adopters, who are people who represent opinion leaders. I'm sorry, I just want to make sure I'm on the right one. So early majority are people who are rarely leaders, but they do adopt new ideas before the average person. That said, they typically need to see evidence that the innovation works before they're willing to adopt it. Strategies to appeal to this population include success stories and evidence of the innovation's effectiveness. Next, we have the late majority. These people are skeptical of any change, only adopt an innovation after it's been tried by the early majority. Strategies that we can use to appeal to this population include information on how many people have tried it and successfully adopted it. And then last, we have the laggers. They're bound by tradition. They're very conservative, very skeptical of change, and the hardest group to bring on board. Strategies that you can use to appeal to them include statistic, fear of appeals, pressure from other people in the other adapter categories. So, readiness for change. So it will be important to assess readiness for change and recommend various strategies for creating it if your organization isn't ready to begin a project. Organizational readiness for change is a multi-level, multifaceted construct. It refers to the organization's shared resolve to implement a change and the shared belief in its ability to do so. It will vary depending on how staff value the change, appraise the implementation, including the demands of the task, such as workload, resource availability, and situational factors. When an organization's readiness is high, staff are more likely to initiate the change, exert greater effort, exhibit greater persistence, display more cooperative behavior. This results in a more effective implementation. And this is why it's critically important to work to address any gaps before you begin a project and to ensure your change team has influencers who can help to shift the readiness pendulum. So, next slide. So, you will need to work to optimize your testing ideas to ensure that what you're implementing doesn't destroy productivity. The changes must maintain, enhance, and balance workforce efficiency. Devote equal attention to blending changes into clinical care workflow as you would do to the evidence-based guideline. This is why it will be critically important for you to start small with your PDSAs and plan small tests of change. We'll be talking about this more in future classes. You will also want to test under certain different conditions, such as your day shift, your evening shift, or night shift. Remember, not every solution will lead to improvement. And if you only test one patient on one day with one physician and look at that and then tweak it, that's how you can bring about change. So the next slide. So congratulations, everyone. We've completed our first class. You can see all the areas where you can start looking at, and hopefully you have some questions for us in chat. And don't, I know we're right at the end of this, so certainly if you have questions when you come on Thursday, we can answer those questions. So come prepared. Carla, Lisa, do we have any questions we can deal with in the next 4 minutes?
I don't see any questions right now, Gloria, but I'm sure people are probably trying to sift through these all these great links that we were able to provide for the materials for the class. And I would like to encourage folks to particularly take a look at that driver diagram link, because we're going to be continuing with that on Thursday.
Absolutely. And we've gone through so much, and we've just kind of really skimmed over it today. And we'll be going into all of this in much more detail as we go through the next 5 classes.
Absolutely. And we'll be sending you links to the slide deck. Yes, I see Michelle just asked about that. We will be sending links to all of the resources in the slide deck, and you'll be getting that in your email. So stay tuned for that. And, we hope to see a lot of you on Thursday. So, we can follow up with any questions you may have. And I think I saw there was an issue with one of the links, but we'll send you everything in an email. So make sure that you have access to all that. Yeah, thank you.
Yeah, I'm going to make a confession that due to technical difficulty, I had to manually type in all these links.
Oh, no.
I'm going to take the So I'm going to take the hit on that, but we're going to be providing them again
Absolutely.
as a follow-up. Thank you, Laura.
Yeah. Thank you, everyone. Thank you for being here today. We'll be in touch.
Have a good
Thank you all.
All right. Bye now.
Bye-bye.